Okay. Assalamu alaikum, ladies and gentlemen. My name is Omar Ahmad. I'm a fifth year medical student, and today I'm happy to give you a session on endocrinology clinical questions. So, this is third year, I believe, endo. So, we're going to be diving into many different things related to the endocrinology part, a growth hormone and its relations, prolactin, thyroid hormones, and then also you have the adrenal hormones like aldosterone and yeah, so we'll see all of them. Now, before we dive into it, I just want to give you some introductions to the types of questions I ask. So my types of questions, I don't really like, these simple 1+1 questions. You'll probably thinking, what does that mean? Like, I'm not going to give you a disease and say, oh, what is the diagnosis? Like, I'm not going to say the patient has hyperthyroidism. What is the diagnosis? I don't really like those types of questions. I like the longer types of questions where it gives you the whole scenario of a person with hyperthyroidism, for example. It's telling you all his diseases, his signs, his symptoms, then the lab diagnoses he's having, and then it might even tell you the diagnosis, and then you think of a treatment. So in when these types of questions, it stimulates your mind. Why? Because you can look at the disease in the whole picture, in its whole picture. You're looking at its clinical features, so you want to memorize their clinical features. You want to understand their clinical features so you can distinguish clinical features between two different diseases. And then you look at the diagnoses. Why do you need diagnoses? To further support the disease you might have in your mind that you think the patient's having. And then after that, management and treatment. So seeing all of these in each question will help you remember and understand the diseases better, and especially distinguish them from each other. Okay, so let's dive into the first question. Like I said, I mean, I didn't say this time. I've said it in my previous sessions. I'll let you read the question and then give you a few seconds, and then we answer it together. So this is the first question. So if you have the answer, please put it in the chat. Thank you very much. Okay, we'll dive into the question. So I'm gonna read it with you just so you can see how I think about a question when I read one, okay? So a 27-year-old woman, right there, you might be thinking that's irrelevant, that's very relevant. You realize that it's a 27-year-old woman that already helps you distinguish like your diagnoses. It's going to be something related to the younger generation. It's going to be something related to women, etc. Come to the evaluation for infertility. That's her main complaint. Okay, the patient and her husband have been trying to conceive, unsuccessful. Her menses are irregular as well, and then she has headaches and bilateral temporal visual field defects. Okay, now, this should all now headaches and bilateral temporal visual field defects. That should make you think of something related to the brain. Okay, something related to the pituitary adenoma, specifically due to the bilateral temporal visual fields, because that's where the optic chiasm lays. And optic chiasm is in relation to the pituitary gland. So when the pituitary gland enlarges, it can compress the optic chiasm, and you're gonna not be able to see the outer visual fields. Other ways a question might tell you bilateral temporal visual fields is by telling you, oh, when a patient's driving, they can't see the outside parts. They're getting into too many accidents by hitting people from the left and right. Okay, so what is the most common? So now we're thinking of pituitary adenoma because of these symptoms and the infertility. What is the most common cause of pituitary adenoma? The answer would be prolactinoma. A prolactin secreting adenoma is the most common cause of prolactinoma. Why is not A and B? First of all, A is very rare. Thyroid hormone pituitary adenomas are extremely rare. And these aren't the signs and symptoms of thyroid hormones. We're going to see what the signs and symptoms of they are, as well as ECTH. ECTH would lead to hypercortisolism, known as Cushing syndrome, and that's going to also have different signs and symptoms. So the answer here is prolactinoma. And so this is prolactinoma. Let's see what it's talking about. Now, the way you want to understand prolactin and an increase in prolactin is that there are two consequences of increase in prolactin. One, you have the prolactin and its own as a hormone, the effects it has as it's on its own. For example, causing galactorrhea. Okay, galactorrhea, which is milk coming out of the nipples, is due to prolactin. However, if you look at these other things, oligomenorrhea, infertility, decreased bone density, how does that arise? That arises from prolactin leading to the inhibition of GnRH. Now, this is more related to the repro, but it's all together, okay? Prolactin inhibits GnRH, which leads to a decrease in FH and FSH and LH, which will lead to a decrease in estrogen and progesterone. And that's why you're going to have these symptoms of infertility, hot flashes like, and as if she's menopausal, no estrogen, and oligomenorrhea. So that's what you want to remember. Prolactin leads to a decrease in estrogen and progesterone, and that's the signs and symptoms you're going to get. Of course, you're also going to have mass effect symptoms due to the pituitary, the tumor itself, like we just mentioned, the headache and visual field defects. In men, you're not gonna see galactorrhea as common. Instead, you're gonna see infertility, erectile dysfunction, gynecomastia. Okay, but you're more likely to see these questions in women. Okay, because it's more common in women. So what do you do next? Okay, now this is the question. Okay, so okay, I'm giving you one clinical scenario, but I can give you multiple questions in it. Okay, now you see a patient with prolactin secreting tumor. You think she has a prolactin secreting tumor. What are you going to do next? What's the best next step in diagnosis? I'll give you two options. One, imaging of the pituitary, like MRI, or two, lab levels. Of course, you want to go with lab levels first. So first, you're going to go with pituitary. I'm sorry, with prolactin levels. As you can see here, serum prolactin is going to be high. Okay, you want to rule out renal efficiency. This is a bit more detailed. It's not really in your lecture, but it's because renal efficiency and hypothyroidism can also lead to a high prolactin. And then if it's high, then you want to do an MRI of the pituitary. Once you do the MRI of the pituitary, what's the next step? You want to treat the disease. How do you treat prolactinomas? You always start with dopamine agonists. Cabergoline, do you guys remember why? You should remember your physiology, because dopamine from the hypothalamus inhibits the release of prolactin in the pituitary. So the more dopamine you give, the better. Okay, so cabergoline is a dopamine agonist. And then sometimes, usually this is enough, but sometimes they might go for surgery, okay? So that's what I want you to remember for prolactinoma. Three very important things. What are the signs and symptoms? How do you diagnose it? The pathophysiology behind it, okay? Which hormones are increased and decreased? Because I might ask you a question that, oh, which of the following hormones are decreased? And you need to tell me that estrogen is going to be decreased. You need to tell me that LH and FSH are going to be decreased, okay? And then also how to diagnose it. You want to remember the imaging of choice is MRI of the pituitary, not CT scan. Do not choose CT scan or X-ray. The first thing you want to do is MRI على طول. Even if it's, oh, don't you do CT first? No, it's MRI. Okay, great. Let's move on to the next question. Okay, so let's dive into this question. Oh, it's only me and you. Okay. Okay, so a 56-year-old woman, chronic kidney disease, SLE. She is has recurrent kidney stones. Okay, that's you need to keep that in mind. Now, if you look at her results, what is high, what is low? You can see that her calcium is a bit high. Okay, EGFR is low, but it's not very low. She's chronic kidney stage disease 1 or something. It's still not very severe. Phosphorus is low, a bit low, and then the parathyroid hormone is very, very high, 800. Okay, it's extremely high. So which of the following is the most likely diagnosis? Now, I hope you are either thinking A or B. Okay. Now, why not? Okay, let's see the answer first. The answer is primary hyperparathyroidism. Now, you might have chosen secondary, which is not a wrong choice. Okay. What's the difference between primary and secondary hyperthyroidism? Primary hyperparathyroidism is most commonly due to parathyroid adenoma or parathyroid hyperplasia, which leads to a very high level of PTH. Okay. And then what is the effect of PTH? Is that it's going to lead to calcium reabsorption and phosphorus secretion in the kidneys. Okay. And that's why you're going to have high calcium and low phosphorus. As a result of the hypercalcemia, you're going to have the signs and symptoms of hypercalcemia. What are the signs and symptoms of hypercalcemia? Bones, stones, groans, and psychiatric overtones. That's something like that. So bones, you're going to have bone pain. Stones, you're going to have kidney stones. Groans, you're going to have constipation or diarrhea. Okay? And then psychiatric overtones, you're going to be like depressed. You're going to be sad, irritated. These are the four. That's it's not mnemonic, whatever it's called, the saying, okay? To help you. Now, Umar, why is it not secondary hyperparathyroidism? What is secondary hyperparathyroidism? Secondary hyperparathyroidism arises most commonly in patients with chronic kidney disease for a very long time, okay? And usually severe chronic kidney disease, like stage 5, where GFR is in like 20s, 15, 10, okay? And sometimes even though in the patients that need dialysis. Now, the main difference you want to remember between primary and secondary hyperparathyroidism are these labs, okay? So why does secondary hyperparathyroidism happen? Because the kidneys are not functioning properly, okay? Calcium cannot be absorbed and phosphorus cannot be secreted because that's the main function of the kidney. So as a result, calcium is not being absorbed. You're going to have low calcium. The low calcium is going to really lead to feedback stimulation of PTH to increase, okay? And that's why you're going to have low calcium and high parathyroid hormone. Instead, in this case, you have high parathyroid hormone and high calcium. So that's the difference, okay? Why is it not excess vitamin D intake? Because if you had excess vitamin D intake, you would have high calcium, but then your parathyroid hormone would be normal. Because why should your PTH go up if you already have enough calcium? The PTH being high in a parathyroid adenoma is because of course, it's a tumor, it's abnormal, so there's a high secretion of PTH, okay? So this is why, remember, understanding the physiology is extremely important for these endocrine questions because they're all interconnected to each other, the feedback mechanisms, and understanding how every hormone relates to its associated other hormone or anions and calcium, stuff like that, okay? So yes, why is it not secondary even though she has CKD? Because she has low CKD, it's usually severe, and her calcium would be low, okay? So this is just explanation. Remember, PTH is high in primary para. And then symptoms of hypercalcemia, kidney stones, bones, stones, groans, okay? So if you're reading this, if you want to read this later. Next question. So since no one's watching and it's all going to be recorded, basically, you please press pause, answer it, and then unpause. Okay, let's dive into the question. So a 56-year-old woman, weight gain, fatigue, and increase in difficulty in lifting heavy objects and climbing stairs. What can that mean? It might mean that, oh, she's having muscle weakness, okay? The patient has moderate asthma, not really that significant. She's using inhaled steroids, okay, maybe. Blood pressure, she's hypertensive. Pulse normal. Symmetric, exactly. Symmetric proximal muscle weakness. And she's hyperglycemic as well. And her 24-hour urinary cortisol is increased. So this means they already dove into hypercortisolism as a differential diagnosis in this question, and they are screening for Cushing syndrome. Okay. Now, before we continue this sentence from further, look at they just mentioned 24-hour urinary cortisol. So let's dive right back from the beginning. So you have women, okay, Cushing syndrome is more common in women. Okay, they get the signs and symptoms they get. They're fatigue, they have tiredness, they have muscle weakness. As a result of muscle weakness, it's hard to lift objects and climb stairs. They're also going to have hypertension and hyperglycemia. These are all combined together for Cushing syndrome, okay? Now you think of Cushing syndrome. Remember my first slide. The next step is lab diagnostics. How do you screen for Cushing syndrome? You have three mechanisms in which two need to be positive. The three mechanisms are one, 24-hour urinary cortisol, like they did, or a low-dose dexamethasone test. Remember, low-dose dexamethasone test. What does that mean? It means you give a low dose of a steroid and you see is the ACTH high or low. Okay? If the ACTH suppresses, that's a normal response. If the ACTH is still high, that's abnormal response. Okay, for example. And then the third test is overnight salivary cortisol. So two of these are positive. You go to the next step. So this is what they did the next step. You check serum ACTH levels, okay? And if they're high, then you want to do. So we already did the low dose dexamethasone. Remember, now we want to do the high dose dexamethasone. If ACTH is high, we want to do the high dose dexamethasone. And in this scenario, we can see that high dose dexamethasone suppresses cortisol levels. Okay, so why is this important? You're going to see in a bit. Now, which of the following is the most likely cause of this patient's symptoms? I hope your answer is D. Okay, now why is it D? Good question. Okay, so first of all, let's talk about the Cushing syndrome. So this is Cushing syndrome. You have central obesity, skin atrophy, purplish striae, Okay, glucose intolerance. Like I said, um, these are the diagnostics you do. Okay, the three ones I mentioned. This is another picture. It can help you. Okay, amenorrhea, remember as well. So a woman will be telling you her periods are irregular. Okay, so this is it. Okay, so after you screen with the three methods I mentioned, okay, uh, which were these three methods, you want to look at ACTH levels. Okay, if ACTH levels are suppressed, that means the cause is either an adenoma, adrenal malignancy, or exogenous. Let me explain to you a bit of the pathophysiology of Cushing syndrome and disease first, okay? Now, it mainly leads to hypercortisolism. The question is the hypercortisolism due to an independent increase in cortisol only, or is it due to an independent increase in ACTH, which leads to high cortisolism? Of course, in the end, it's always there's always going to be high cortisol. But the question is ACTH involved or not? Is it dependent on the ACTH or not? Okay. So, so great. So that's the question. So now after it's positive, you want to check the ACTH levels. If it's suppressed, it means that the hypercortisolism is not coming from ACTH, it's coming from cortisol itself. So the patient might have an adrenal adenoma that's secreting cortisol, or they might be taking exogenous cortisol, okay? On the other hand, if the ACTH remains normal or elevated, it might mean that the ACTH is the cause of high cortisol, okay? Um, Now, when it's normal or elevated, you want to do a high dose dexamethasone suppression test. Now, a high dose dexamethasone, um, if the ACTH is still high after a high dose dexamethasone test, it means that there's an ectopic ACTH production. What does ectopic mean? It means that there's ACTH being produced from another site. Like what? Like the most common is lung cancer. Okay. So on the other hand, if after a high dose dexamethasone test, the ACTH decreases, it means it's most likely a pituitary adenoma. Okay. So this sequence is very important. The sequence of first doing these screening tests and then checking ACTH levels uh, to figure out. So we can see here that the ACTH was high, and then it was suppressed by high dose dexamethasone, which means it's going to be adrenal adenoma. Remember, I don't want you to memorize this. Okay, you need to understand the pathophysiology behind this to understand to you don't need so then you won't need to memorize it. Okay, now this is a explanation if anyone wants to read it later. Okay, now this is the next question. Okay, so it seems someone has already answered, and the two people have answered C. That's great. That's the correct answer. Okay. Um, can you guys hear me, by the way? Okay. Okay, great. Okay. So let's look at this question. A 44-year-old man, progressive joint pain, back and joint pain. His knee and ankle joints are stiff. Excessive sweating, ring and shoe size, okay, protruding jaw, widely spaced separated maxillary teeth, crepitus. So this all should make you think of acromegaly. Okay, the diagnosis here is probably acromegaly, especially due to the increase in shoe and ring size, the joint pain. That's most likely also the enlargement of the forehead and this widely spaced teeth. Okay, that's all very unique to acromegaly, which is high growth hormone. It doesn't really happen in other diseases like hypercortisolism. We just saw what Cushing syndrome has, so it shouldn't be A. Now, why is it not B? Okay, some of you might have chosen B, but the answer is not B. Why? Because in acromegaly, growth hormone, remember the physiology behind growth hormone is that it always goes up and down. Okay, it's never stable. So sometimes you might get it and it's low, but that's not the correct answer. That's not the correct lab diagnostic. Okay, so instead you want to choose C, which is the insulin growth factor 1 levels. So that's the screening test. Now remember, this is acromegaly, as I said. Okay, these are the symptoms and signs and symptoms related to it. And diagnostics very important. First screen with IGF. Okay. If it's high, then you want to confirm it with an oral glucose tolerance test, OGTT, and measure growth hormone levels. What is the physiology behind this? is that growth hormone is suppressed with glucose. So if you give glucose and growth hormone is suppressed, that's a normal response, and then it means it's most likely not to acromegaly. However, if you give glucose, okay, or glucose tolerance test, and growth hormone is still elevated, it means that it's most likely acromegaly. After you diagnose that, then you want to do a pituitary MRI because it's most likely a growth hormone secreting adenoma. And then the treatment can either be somatostatin analogs like octreotide, okay, octreotide, remember, or usually they also might do surgery. Surgery is also might be needed, okay? So let's move on to the next question. Does anyone know the answer? Yes. So the answer is correct. They chose D. So let's look at what's happening in this patient, okay? Increased fatigability, weight gain, um, she's getting tired, okay? Also has bradycardia, pulse 55, okay? Hair loss involving the lateral third of the eyebrows, delayed relaxation of the deep tendon reflexes. Now this is so easy. Like when you later on when you're studying for any boards or something, delayed relaxation of deep tendon reflexes in endocrinology only happens in hypothyroidism. So the question is, do you choose C or D? The first test in thyroid disorders is always going to be TSH levels. It's never going to be the free thyroid and T4 and T3 levels, okay? That's something very important to remember. You always want to check TSH first, if TSH is low, normal, or high, okay? Now, I have another question for you guys. So, what do you think the TSH level will be in this patient? Will it be high or will it be low? So, will TSH be high or low? That's a question for the chat. So TSH will most like why do you guys think it's gonna be low? What do you guys think the patient even has? Exactly. TSH will be high. Exactly. So this patient has yeah, exactly. So exactly. Okay. So this patient has hypothyroidism. Okay, as we said, always check first T4. These are the common signs and symptoms that come with it. Constipation, okay. Loss of hair, tiredness, it's very easy. That's why they won't usually tell you to diagnose it as hypothyroidism because it's very easy to see the diagnosis itself. They'll usually be asking you questions about its treatment or how to diagnose it through labs, ultrasound, whatever you need, etc. Or what is the most common cause? And the most common cause is Hashimoto thyroiditis, okay? Like someone mentioned in the chat, Hashimoto thyroiditis. Remember, if a patient has Hashimoto thyroiditis, they might also likely have family history of other autoimmune diseases like a celiac disease or type 1 diabetes. Okay, so that's other things you will see in the question. Okay, so let's move on. So okay, exactly. The answer is A. So Graves, exactly. Someone said Graves. Okay, that's exactly the answer. Okay, so this is easy. Okay, trouble sleeping, palpitations. These are now. This is the opposite. We just saw hypothyroidism. Now we're seeing hyperthyroidism. Okay, so the thyroid is diffusely enlarged because of the antibodies stimulating the thyroid to increase production of thyroid hormone. Now, an important part here is the positive assay for thyroid tropin receptor antibodies that is sensitive and specific for Graves' disease. Okay. Now, something that's very now that we know that it's most likely Graves because of the antibodies, we can think what are the other symptoms and signs that come with Graves, and that's most likely a exophthalmos, which I'll show you a picture of right now. B, we said that happens with what? It happens with acromegaly. C, gynecomastia is going to happen in prolactinoma. D, hirsutism is going to happen in cortisol syndrome, cortisolism, Cushing syndrome. Okay, so this is hyperthyroidism. You get anxiety and insomnia, palpitations, heat intolerance. Okay, they'll tell you they're always sweating. Weight loss. Okay, they'll tell you they're also diarrhea. So they're losing weight without even trying. Goiter, hypertension. Okay, atrial fibrillation is also very important to remember because you guys already had CVP, so never mind. But this is atrial fibrillation is very important to remember. And in fact, now this is kind of steering away, but in any patient with atrial fibrillation, you will always want to check for TSH levels, okay? Because hyperthyroidism could be a cause. So this is exophthalmos, as you can see, enlarged eyes, okay, and it's just bulging as well. That's the main thing. The idea is that it's bulging. And so yeah, so this is just an explanation for anyone who wants to read it later. Now, next question. This might be a hard question, actually, I think. Never mind, mashallah, you guys are all smart. So yes, the answer is C, absence of parathyroid glands. Now, why are we thinking that? Okay, why do we think it's absence of parathyroid glands? First, exactly. So someone mentioned Trousseau sign, okay? So painful muscle cramps, tingling sensation around his mouth, okay? Schwastic and Trousseau sign, okay? Tingling sensation happens with hypocalcemia. Uh, Physical examination, light tapping anterior to the ear. So these are all the signs that are related to hypocalcemia. Now, if you look at the patient's history, uh, okay, actually before that, what is the most common cause of hypocalcemia? It's a lack of, it's absence of parathyroid glands. And what is the most common cause of absence of parathyroid glands? Sorry, the most common cause of hypocalcemia is not absence of parathyroid glands. What I meant is the most common cause of hypoparathyroidism, okay? Hypoparathyroidism, the most common cause is exactly surgery, okay? And this patient says he has surgery here, so that's the most likely answer, C. Now, why is it not A? Why is it not A or D? Because that would lead to hypercalcemia, which would lead to the symptoms we said of bones, stones, groans, psychiatric overtones. Instead, the patient here is having hypocalcemia. Okay, so ignore the part on the left. That's for anyone that wants to read. So this is Schwastic sign, the one on the left, the one the patient just had. And now we can see the difference between hyper and hypoparathyroidism. Tingling, like the patient just had numbness around his mouth, muscle spasms as well. And the most common cause of hypoparathyroidism is surgery. So yes, that's the correct answer. Okay. Also remember the lab levels because I could change this question and ask you what are the most likely labs levels going to be, and you will tell me that the PTH is going to be low, the calcium will be low, and the phosphorus will be high. Okay. So there's this one question I can ask you one scenario I can ask you 6 different questions about. So that's why these long clinical scenarios are very fun. Okay, next question. Okay, someone answered. Someone said D. That's okay, great. Correct answers. So first of all, what does this patient have? Okay, 20-year-old woman, she's young. Okay, and immediately you can see from the glucose extremely high. So are you thinking of type 2 diabetes or type 1 diabetes? Most likely type 1 diabetes. But is it diabetes? You look at this, okay? Lethargy, abdominal pain, nausea, polyuria, excessive thirst. These are all symptoms, signs and symptoms of um, type 1 diabetes, especially DKA, okay? So now there's this one part that's a bit more detail, which I'll give you. She also complains of dysuria and chills. Is dysuria and chills signs and symptoms of type 1 diabetes or DKA? So I'm going to make it short. The answer is no. But why is this important in this case? Because DKA, diabetic ketoacidosis, usually has something that initiates it. You know, it usually has a factor that leads to it. So it can either be surgery. You know, a young patient might have surgery. It can be trauma. Or it can be infection. Infection is one of the more common causes, stress and infection. So this patient dysuria was most likely a UTI and this infection led to DKA. So remember, these are just ways they can direct you into recognizing that it's DKA. Now, it's very important to understand the lab diagnostics of DKA. Okay, so these are the diagnostics of DKA. You're gonna have hyperglycemia, and what happens in DKA is that there's low insulin. Okay, as a result, you're gonna have high glucagon because insulin would affect glucagon. At the same time, there's gonna be ketoacidosis. Keto acids, since they're acids, they're gonna lead to a decrease in the pH, and which is gonna lead to a high hydrogen photons. You're gonna have low bicarbonate. Why are you going to have low CO2? Does anyone know why you're going to have low CO2? Because you're going to have reflux tachypnea, okay? The patient's going to be exactly hyperventilating, okay? Anion gap is extremely important because this is one of the causes of high anion gap metabolic acidosis, okay? Now, the very important question is potassium depletion. Okay, we're going to have low potassium, right? Um, is potassium in this question? Unfortunately, I have not included potassium in this question, okay? But let's say potassium here, is it going to be high or low? That's the question. High. Okay, exactly. Now, now this is a tricky thing, and I hope I can explain to you guys properly. There is okay, exactly. Someone just mentioned it. So it can lead to arrhythmia, and that's what you're gonna see as part of the so hyperkalemia can lead to arrhythmia, and that's what we're gonna see as part of the treatment. So like I said, you give insulin, which is the normal insulin you give, regular insulin, okay? After that, you can give IV insulin, sorry, it's called regular insulin. Follow and replace potassium if needed. Sometimes it's already high, and you might not need to replace potassium, okay? So yeah, and this is also a question that might come is that what are the levels of fatty acids going to be in the patient? And they're going to have high fatty acid levels. Okay, so does anyone have a question so far? This is the next question. So someone asked about hypokalemia in diabetes type 1. And so remember, when you give insulin, okay, in diabetes, in DKA, when you give insulin, insulin can lead to of the uh, a shift of potassium inside the cells, okay, when you give insulin. So as a result, you might have hypokalemia. Not always, you might have hypokalemia, and that's why you need to monitor the potassium levels, okay? Now, this question is, okay, so someone said E. Finally, we have a mistake, that's the, okay? And then someone said C. Yes, I'm glad a hard question has come in, okay? So let's read it together. Let's read this. Oh, wait, Wait, I just realized that I put the answer in the question. Okay, it literally says which of the following is the most likely cause of this patient's adrenal insufficiency? It's B, but we'll see why. Okay, anyways, so a 3-week history of weight loss, nausea, abdominal pain, and postural dizziness. What are those signs and symptoms? That's related to many things, but we'll see what it is related to. Now, someone said C, okay, exogenous corticosteroid. Now, I'm gonna assume they said C because of the oral prednisone, which is a good way of thinking, and that's why this was included in the question to trick you. But you will realize why it isn't that, okay? She also has hypothyroidism. Now, see, that's very important to realize that she also has hypothyroidism. What did I just explain to you guys before this? I explained that Hashimoto thyroiditis might have associated autoimmune diseases. Like what? Like I said, celiac disease, type 1 diabetes. Another autoimmune disease is also autoimmune adrenalitis, primary adrenal insufficiency. So these are all very like you might think this is all excess information, but these are things you see in real life and in questions ways for you to narrow down your diagnosis. Okay, so she's hypotensive, pigmentation at the palmar creases. This is very important, and this is why E is incorrect. Okay, because of the palmar creases. Where does the palmar creases come from? The increased pigmentation. The increased pigmentation comes from high ACTH levels, and the high ACTH levels convert is also has a byproduct as melanin, and that melanin increase in melanin will lead to the pigmentation. So the high pigmentation, you know that the pituitary is normal. Why? Because there's a normal or a high release of ACTH level. Does everyone understand, the three people with me? Did you guys understand the point I just mentioned about the ACTH and melanin? If not, I can repeat it. Exactly. Okay. Wait, someone said yes. Oh yeah, okay. Someone said yes, please. So look, the pigmentation, where does the pigmentation come from? It comes from melanin. Where does this melanin come from? It comes from ACTH. Okay, the ACTH precursor is also something that leads to an increase in melanin. Okay, so the fact that melanin is there means that ACTH is also there. The fact that ACTH is also there means that the pituitary is functioning normally. And you know that the disease is not from the pituitary, it's from somewhere else, most likely the adrenals. If the patient didn't have the pigmentation, then you might think that, oh, the disease could be from the pituitary because there's low ACTH secretion and low melanin secretion, okay? So let's move on. So hyponatremia and hyperkalemia, what is that as a result of? It's as a result of low aldosterone levels because aldosterone monitors these two serum ions. Okay, it makes sure there's normal sodium and normal potassium. So yeah, okay, I didn't explain to you C why C was wrong yet. So let's okay. So the answer here is primary adrenal insufficiency. They also did a test confirming that the serum cortisol was low. Okay, so cortisol is low. So C would be after stopping the drug. Exactly. So C, first of all, if the patient was taking oral prednisone, and then she would have Cushing syndrome. She wouldn't have uh, decreased in adrenal and cortisol. She would be having Cushing syndrome. She'd be having hypertension and high cortisol. She wouldn't be having low 8 a.m. cortisol because they would be high. Exactly. Okay. So let's move on. So this is the explanation. So the patient most likely has primary adrenal insufficiency, which the most common cause is autoimmune adrenalitis. Okay, these are the clinical features: fatigue, weakness, anorexia, hyperpigmentation. Remember, important. Nausea, vomiting. Okay, like you won't see nausea, vomiting, and abdominal pain in other hormone decreases. Okay, like if prolactin is decreased or thyroid is decreased, you won't commonly see nausea, vomiting, abdominal pain. So remember this. Okay. Laboratory findings, most important are these two, hyponatremia and hyperkalemia. Okay. Why? Because there's decreased aldosterone. With a decrease in aldosterone, you're going to have increased potassium and decrease in sodium. Okay. I hope I explained that properly. Sorry, I feel like that part I got a bit confusing, but yeah, I hope is understood properly. That everyone understand everything I said in the past in this question. Okay. Let's go on to the next question. Okay, so yeah, the answer is A. So what does the patient have? First of all, he's a 28-year-old and he's coming with elevated blood pressure. Is that normal? It's not really normal. When a patient is at this age is young and they have hypertension, usually you want to go check other secondary causes of hyperaldosteronism. Okay, that's why the answer is not D. It's not primary hypertension because that would have been an older patient. And that's the other causes of why it's not primary hypertension. Okay, so if we move on, you can see he's very hypertensive. His serum potassium is low and sodium is high. Why? Because aldosterone leads to secretion of potassium and reabsorption of sodium. So that's another clue that points to hyperaldosteronism. Now to understand now to screen hyperaldosteronism, you also want to check the ratios of aldosterone to plasma renin. Now, if you remember the physiology behind renin and aldosterone, a high renin released from the kidneys will lead to increase in angiotensin 2 and as well as the aldosterone, which will lead to hypertension. Okay, but if aldosterone is already high due to an adenoma, that's going to lead to negative feedback, which is going to lead to a decrease in plasma renin. Okay, and how do you take that into consideration is by looking at the ratio of these two together. So if aldosterone is high and renin is very low, and you have a high ratio of I above 20 or something, okay, then that points towards an adenoma that is secreting aldosterone. So the answer here would be A, an adrenal adenoma. Okay, why is it not C, serine secreting tumor? Because of the ratio. If renin was also high, it would be a ratio of almost 1 to 1 or 5 to 1 or much lower. Okay, so this is so the left is explanation for anyone that wants. On the right is I'll help you guys here. So hypertension, hypokalemia, also metabolic alkalosis. Okay, you're gonna have a high bicarbonate level. Okay. So this I explained it. And remember, a screening test. So if you remember for a growth hormone screening test, what you did is that you gave glucose and you checked the whole growth hormone level, if it decreased or increased. Why? Because glucose inhibited growth hormone. In the case of aldosterone, you give um, oral saline, okay? Because saline will inhibit aldosterone level. If you give saline and the aldosterone is not decreasing and it's still staying high, that also confirms the diagnosis. And then you want to do imaging after that. For most of these diseases, they always require imaging to detect an adenoma. The most common cause of adrenal hyperaldosteronism, primary hyperaldosteronism, is due to unilateral adrenal adenoma. And the second most common cause is bilateral adrenal adenoma. Okay. So the differences between the two are important for the treatment as well. If it's unilateral, you can do surgery and just resect it. However, if it's bilateral, then you want to use aldosterone antagonists like spironolactone and eplerenone. Now, I might dive into a bit more pharmacology. What is some side effects of these medications? Spironolactone might lead to gynecomastia. Okay, eplerenone doesn't. So yeah, so if that's the explanation for this primary hyperaldosteronism. Now, next question is diabetes. Okay, the answer is B. Okay, so what does this patient have? So if you look at the end, I mean, they're asymptomatic. She has no current complaints. Okay, but her, if you look at the end, it says laboratory testing is significant for blood glucose above 140 on more than 2 occasions. So that is a diagnosis of type 2 diabetes. Remember, how do you diagnose type 2 diabetes? Either through if a patient has a random, remember these, it's very important to remember how to diagnose the criteria you need to diagnose diabetes, okay? Either fasting glucose of more than 125 or a random glucose of more than 200 and the patient has symptoms. And the third most common one that they use is also HbA1c levels, okay? The HbA1c, it measures your glucose over the last 3 months, something like that. And if it's above 6.5, then you diagnose type 2 diabetes, okay? And the most common cause of mortality in type 2 diabetes is myocardial infarction. It's not the other three. You might get the other three in diabetes. These are the diabetes complications, chronic kidney disease, okay? Also infection. DKA. Is DKA a complication of type 2 diabetes? It's very, very, very rare that we even say that it's not really a complication of type 2 diabetes. It more often happens with type 1 diabetes, okay? So myocardial infarction, they are much higher risk than the general population, okay? Now, next question. So the answer isn't C. Does anyone have another thing? Yeah, so the answer is E. Okay. Now, so this patient, they have a thyroid nodule. Okay. They're asymptomatic, no heat or cold intolerance. Okay. Uh, but they have a thyroid nodule. Now, like I said in the beginning of this test, in the beginning of this session, that the first thing you always want to do is that you want to check for uh, thyroid levels, TSH first. Always want to do thyroid stimulating hormone before you do anything else, okay? And then that's gonna let you know the next steps you want to do. So the other choices, C and D, you will realize when they come to play a role. Right now, let me explain to you. So so this is okay, this is a very good flow diagram to figure out when you do what, okay? So the first thing, of course, you want to do is TSH and a thyroid ultrasound. Now, depending on the TSH level, whether it's high or low, is will be your next step. Now, before I tell you the next step of what when you do FNA or radioactive iodine, you want to think of why you do each of these, okay? So the differentials you're gonna have in the thyroid include hyperfunctioning thyroid nodule, toxic nodule, or Graves' disease, or it could be a cancer, it could be adenoma. Uh, so if the TS now look in an adenoma, they're most likely cold or hypofunctional. Okay, adenomas don't secrete thyroid hormone. So if they don't secrete thyroid hormone, it means that the TSH is most likely going to be normal or high, right? So if the TSH is normal or high, then you're going to be thinking of a cancer. You're going to be thinking of adenoma. And that's why you want to do an FNA, a fine needle aspiration, because you want to check if there is a tumor. On the other hand, if the TSH is low, what does that mean? If the TSH is low, it means that there's an excess in the thyroid hormone, and this excess in thyroid hormone is most likely occurring due to Graves' disease, a toxic hot nodule, or something like that. And you're less worried that it's a cancer or an adenoma. So, and then you won't do an FNA because you know it's less likely to be a cancer. And instead, you're going to be doing a radioactive iodine scintigraphy, okay, the technetium 99 scan, to check for the uptake of the iodine. And if you guys remember that picture where it's going to be high uptake, it's going to be very black, and that's going to tell you that there's hyperthyroidism. And if it's Graves' disease, what were the treatments for Graves' disease? You can give prednisone, propylthiouracil, um, and then later on, you might even do a hemithyroidectomy or a thyroidectomy, depending on the case, like we saw recently in that one patient that had thyroid surgery, okay? So that's for evaluating thyroid nodules. It's very important. Based on whether TSH is high, normal, or low, it will tell you whether the patient is likely to have an adenoma or just a toxic nodule or Graves' disease. And then you do a fine needle aspiration or radioactive iodine scintigraphy, okay? Did everyone get that? Great. Okay. Next question. Okay. No, so remember, this question is saying which of the following changes are most likely to occur after administration of high dose dexamethasone. It's not telling you what are the normal levels of the dexamethasone, okay? So let's see the answer, okay? So, oh, sorry. So, okay. So what does this patient have? Cushing syndrome again. Okay, E. So someone's at E, that's a good choice. Okay, so the patient has Cushing syndrome and they're a smoker. Okay, they have a chest X-ray showing a lower lobe mass. And now look at this. It says that it's not suppressed by low dose dexamethasone. So they're using those three screening methods. Okay. Now, the next step, like remember, if you guys remember, I told you is to check the serum ACTH level. If the serum ACTH level is high, then you proceed with the the dose dexamethasone test. Now, this patient most likely has a lung cancer. As you can see, he has chest X-ray reveals a right lower lobe lung mass. Okay, so if they have lung cancer, it means they might have ectopic ACTH production. Now, do you guys remember from the slides I showed you earlier? In ectopic ACTH production, what is going to happen after the high dose dexamethasone test? Neither ACTH will not decrease. If ACTH decreases, it means it's most likely a pituitary adenoma, which that patient had. Instead, this patient is not going to have a decrease in ACTH. There's going to be no change, so we can cancel out A, B, and C, and we can look at D or E. And because ACTH will still stay high, then cortisol will also have no change. So the answer here is E. Okay. So do you guys let me go back to the uh okay, wait. Let me go back to the slide for you guys. Great, here. Okay. Look, remember this high dose dexamethasone test. The patient, they're already telling you that, oh, he has a lung cancer, you know, I mean, he's smoking so much, he has a lung cancer. So then you just assume it's ectopic ACTH production and neither ACTH and cortisol levels will change, okay? And if it did change, then it would have been a pituitary adenoma like our patient had here. Okay, now let's move on to the next question after that. So this is an explanation if you guys want to read it later. So if you don't know the answer, at least tell me, what does this patient have? Adrenal crisis, great. And how do you treat adrenal crisis? Exactly, dexamethasone. Okay, that's great, great. So if you remember, this is similar to our previous scenario where they had hypotension, you know, and they also have the pigmentation on their hands and their body. If you remember, because of the ACTH and melanin idea, hypothyroidism, just again, so this patient probably also has autoimmune adrenalitis, and now they're having a crisis, okay? How do you treat the crisis? You treat it with hydrocortisone or dexamethasone. So what are the signs and symptoms of crisis, hypotension, and shock, which this patient is having right now? Okay. And it's usually all it's similar to DKA, where there's an etiology behind it, you know. The patient either might have had infection or a surgery or something that stimulated this crisis. Okay. So yeah, so someone answered. Okay, great. So now I want to go into some questions from the previous. So the answer is already here. So in case you guys, because they didn't have explanations, I wanted to explain it to you. So this is a question about a 25-year-old female presenting with symptoms of headache and galactorrhea and high prolactin. So pituitary MRI showed macroadenoma of 2.3 centimeters. Okay, so this patient has hyperprolactinoma. Now, prolactinemia. Now the question is, could it be from a prolactinoma or could it be from stock compression? What is the idea of stock compression? Okay, I wanted to take this time to explain that to you. So if you look at this is a picture of the anterior pituitary and this is the hypothalamus. Now the normal physiology of the prolactin hormone is that you have a secretion of that dopamine from the hypothalamus, and this dopamine inhibits prolactin. Dopamine inhibits prolactin, which keeps prolactin at its decreased level. And when you have a prolactin adenoma, What is the treatment? If you guys remember, dopamine agonists, okay? Dopamine agonists are the treatment for prolactin adenomas because dopamine inhibits prolactin, okay? Now, however, you might have a scenario where this whole road here you have of dopamine coming down is compressed by a tumor. If you have a tumor that's compressing this pathway, the hypophyseal portal system, then the dopamine is not going to be inhibiting prolactin anymore, and you're going to have hyperprolactinemia. It's not necessarily going to be an adenoma. It's just going to be a hyperplasia because you don't have any inhibition of prolactin. Okay, so remember this association between dopamine and prolactin. It's very important. So besides just having a pituitary adenoma, you can also have stalk compression from an adenoma, a tumor that's secreting nothing. This tumor could be secreting nothing, but just because it's compressing the stalk, it will lead to decreased dopamine and decreased prolactin inhibition. Okay, so that's an important thing to remember. No, this is no. I don't know if prolactinoma was in the question answers or not. This is, I think, from the 11th batch or 10th. I don't remember. Um, Yeah, but I'm gonna go into a bit more detail. Okay, I don't know if this is required, but you guys exactly. So if this was a USMLE question, okay, now since I've done USMLE, I know how they think. If this was a USMLE question, you know what they'd make you realize that it's not a prolactinoma, even if it was part of the questions, okay, part of the answers. Let me explain. So first of all, look at the prolactin level. It's 113, okay? And look at the size of the adenoma. It's 2.3, which is a macroadenoma. In macroadenomas, prolactin levels are almost always higher than 200. In a macroadenoma, the prolactin levels are always higher than 200. But here it's only 113. So it makes you think that it might not be a prolactin secreting adenoma, but instead it might be a huge adenoma that's compressing the stalk. Okay. Now, let's go back. Let's go back all the way to that diagram I showed you of prolactin in the beginning. Okay. See here. So the serum prolactin is off usually above 200. There was another diagram I didn't include because it was very similar, but it said that microadenomas, it's almost always above 200. So I don't know if you guys might get this question or not, but that's the way you want to think about it. Did you guys understand it, especially you, Umar Abdul Wahab, since you asked the question? That a macroadenoma is gonna have higher prolactin level, more than 200. Okay, yeah, great. I saw a similar question like this in U World and stuff. So, and if you get it in the real exam, it should be a similar concept. Now let's move on to these two similar questions. They're two different questions, by the way, but similar ideas. So let's look at the first question, which is question 5. Okay. And okay. So laboratory investigation showed low TSH, high T4, and no thyroid antibodies. What is the next step? So remember what I told you guys just recently is that if it's low TSH, it means it's most likely an active swelling in the neck. So it's probably not cancer. So instead, you want to do a thyroid uptake scan. You're right. And the second one is the opposite. It shows normal TSH levels. So that might make you rethink of cancer. And instead, you want to do FNA. So yes, correct. Both correct. Okay. You don't do a biopsy. Or remember, this is also important. It's not C. Because in the thyroid, you don't do a biopsy. You do fine needle aspiration. Okay, you aspirate the fluid and you do a fine needle aspiration. It's not going to be a biopsy. Okay, now let's see this easy question. Yeah, it's A. Okay, this was yeah, stroke A MI. Okay, so that's it for me. So that's all some of the questions I had. I tried to finish in an hour. I guess that was the time limit I had. So I just wanted to apologize if I could confuse you guys anywhere. So there was that one question about the chronic kidney disease. So I guess ignore what I said about it and just stick to what the doctor said. And I hope everything else was explained properly. So remember, there you have you have different diseases. You have hyper and hypothyroidism and the different ways of diagnosing it. Um, and the most common cause of hyperthyroidism is Graves' disease. Most common cause of hypothyroidism is Hashimoto thyroiditis. Remember the relationship between the TSH levels and the T4. Okay, so if TSH is high, then it's going to be hypothyroidism. If TSH is low, it's going to be hyperthyroidism. Okay. Also remember the idea of prolactin, the stalk compression, hyperprolactinemia. It leads to infertility, irregular menstruation, galactorrhea in men, gynecomastia, and erectile dysfunction. You treat it with dopamine agonists like cabergoline. You want to do an MRI, uh, not a not a CT scan of it. Okay. Um, Also remember the aldosterone levels, hyperaldosteronism, how you diagnose it, how you treat it. I'm pretty sure we got a question about pharmacology of hyperaldosteronism before, like spironolactone versus eplerenone, etc. Okay, so does anyone have any questions? Okay, someone asked to explain the dexamethasone again. I will. Okay, so let me go back to the question, the slide about it. So this is kind of there's a bit of memorization in this, okay? So although we try to understand more, there's a bit of memorization in this. So let me explain it to you. So a patient comes to you with signs and symptoms of Cushing, okay? What you do is you do the three screening tests, 24-hour urine, overnight salivary, and low dose dexamethasone test. Okay, and if it's positive, then you check the ACTH levels. Okay, if the ACTH is low, it means that there's something that's secreting cortisol itself. It could be adenoma, or it just could be exogenous corticosteroid intake. Okay. On the other hand, if the ACTH levels are normal or elevated, it means that the pathology of the Cushing could be related to ACTH secretion. Okay? Now, ACTH secretion, we need to know the two most common causes of ACTH secretion leading to the Cushing syndrome is either a pituitary adenoma secreting ACTH, or the other cause is ectopic ACTH production, in which small cell lung cancer secretes ACTH. Okay. Now, how do you differentiate between a pituitary adenoma secreting ACTH and a lung cancer secreting ACTH? That you do the high dose dexamethasone suppression test. Okay. Now, in a high dose dexamethasone, so what is dexamethasone meant to do? Dexamethasone is meant to suppress ACTH, right? In us normal human beings. Now, in these patients with Cushing, if the ACTH is high or normal, you give high dose dexamethasone. Now, this part, you just need to kind of memorize it, okay? High in a pituitary adenoma, high dose dexamethasone will suppress the ACTH. Like the pituitary adenoma still has some of that feedback mechanism where high dose dexamethasone will suppress the ACTH from the pituitary adenoma. Okay? On the other hand, if you give high dose dexamethasone, it will not suppress the ACTH in a small cell lung cancer. That's just the way the pathology is. So to conclude, to summarize, a pituitary adenoma will still have some negative feedback and it will be inhibited by high dose dexamethasone. So as a result, you will have decreased ACTH and cortisol. However, in an ectopic ACTH production from lung cancer, the ACTH will still be high even with high dose dexamethasone suppression. So did you understand that? If you didn't, I'm more than happy to explain it again. Okay, great. Great. Okay, no problem. So that's it. Thank you very much. I'm sorry if I confused you guys any place. And yeah, so if you have any questions, further questions, my number and email were at the beginning, and that's it. So yeah.